Okay, well, thank you for that introduction and this robust crowd. I was telling some earlier that I didn't tell you, it was my daughter who gave me the over-under for actual in-person attendance at 2. So this is an impressive turnout. Greeting to those of you in Zoom land as well. These are my disclosures. Worked as an investigator for one of the drugs that we'll talk about today, Dupilumab. I know financial connection, just that I was PI at the site, children for all the age groups. 6 months to 18 for that drug. I have consulted on bringing the clinical trials to the pediatric world for 2 drugs that we will also talk about. Lebrikizumab, which was just approved last week for atopic dermatitis, and Tralokinumab, which has been around for more than a year now. I've been co-chair of the American Academy of Dermatology Atopic Dermatitis Guidelines Committee. I've been a part of the committee since 2004, co-chair in 2014, and now again from the latest iteration. And back in 2004, it was like my father was a pediatrician, and he was always telling me how his board exams really weren't that tough because there was only penicillin. And this was the case in atopic dermatitis land for a long time. But as I told some of those who were here a little bit earlier, my slides have changed very slightly because in the last month, there have been 3 new drugs approved for atopic dermatitis. 1 topical and 2 systemics. The topical was just approved yesterday. So a lot happening in this world. Let's see if this is let's see, down arrow, go. Why is it not going?
Try the side arrow.
I just had to click on it. Okay, here we go. So just by way of outline, we'll talk a little bit about some of the explosion of comorbidities associated with this condition beyond the atopic march, topical therapy, systemic therapy, and then some guideline discordance. As I said, I've been intimately involved with our guidelines in the dermatology world around the same time, using the same system of evidence assessments. You allergy types came out with a nice guideline as well, and there was some interesting discordance using the same way to evaluate the evidence. I just thought that was an interesting thing to point out at the very end. So just as a little teaser with regard to comorbidities, this has been again, dating myself, I say the $64,000 question, the $2 billion question for a long time. Can you prevent the atopic march by treating atopic dermatitis early? And there was some data back in 2014 down. Eric Simpson is a dermatologist at OHSU, who's a very active thought leader in this space, who asked the question, can you just moisturize the heck out of high-risk infants starting at 3 weeks of age and decrease the risk of developing eczema? So this wasn't the atopic march, this was eczema specifically. And sure enough, there's a 50% risk reduction at 6 months. 6 months, this is a very short window, by simply using a petrolatum-based emollient. There's a Japanese group that did the same thing the same year or 2. And so then the question was, gosh, can you prevent eczema by just moisturizing these kids starting at an early age? Then that led to a much larger trial that just came out in the last couple of years that said basically that the larger trial said no, but then there's been even more mixed data since. So open question, but that's a really interesting area of investigation of what can you prevent by intervening early just to try and improve that barrier. Because that's sort of the sine qua non of this disease, right, is the barrier. When I left, I started in internal medicine as well before moving to pediatrics. And when I first went from internal medicine to dermatology, I was stunned at the fact that there was a disease that could be treated by both cyclosporin and Vaseline. I was like, both of them can help a lot. I was like, okay, that's really odd. What weird alien world have I entered in dermatology? This is a more recent question about atopic march and Dupilumab. So Dupilumab you're familiar with, we'll talk more about it. It's a biologic, first biologic approved for systemic medication for atopic dermatitis that wasn't prednisone, approved by the FDA. So that's something. Our least favorite treatment for atopic dermatitis, systemic steroids, was the only FDA approved to treat systemic therapy for that disease until 2017 when Dupilumab came out. Since Dupilumab has come out, now we're using it for the full range of ages. And if you do a meta-analysis, this group did of clinical trials, there was a significant risk reduction in the onset of new allergies in patients treated with Dupilumab for their atopic dermatitis. Interesting. Also, clinical trial, a a curated group of patients, right? Not necessarily generalizable to the world, which is why these clinical trials then we end up using and don't necessarily get the same results in our patient population. So that led this group, Lynn and Al, to do look at real world data. This was just published this year in our journal, the journal Dermatology. The TriNetX US database, good database, and looking at rates of atopic march progression among pediatric patients with Dupilumab versus other systemic agents, specifically cyclosporin or prednisone. And sure enough, patients treated with Dupilumab were 40% less likely, as you see, to develop asthma, 31% less likely to develop allergic rhinitis over a 3-year period. So longer lens that they were watched for, but still not perhaps long enough. But intriguing nonetheless, knowing that we've got this explosion of comorbidities that have been linked, putatively linked to atopic dermatitis. This was our publication. For those of you who came late, the one disclosure I do think is really important to state is that I'm co-chair of the American Academy of Dermatitis Atopic Dermatitis Guidelines Committee. So the American Academy of Dermatology is very specific with me that when I speak and I make a point that I say that's my opinion versus what's something that we published based on the evidence. This is what we published based on the evidence. This is our publication 2022, looking at comorbidities in adults. And as you can see on the left, the green, that's the atopic march, right? No surprises. A little closer to the right on that next bar over, things like alopecia urticaria. If you've seen patients, you obviously see patients with atopic dermatitis. If you're sometimes struck by, man, it seems like I see a lot of alopecia areata in this patient population. That's not a coincidence. That's a fairly strong connection there. Urticaria is not a surprise to any of you guys. The other green ones, depression, anxiety. You know, for I'm preaching to the choir here, but when I talk to primary care providers and they first of all throw out terms like just eczema, I start to cringe because I don't like those two words put together. If you've got eczema that gets better with Vaseline, sure, it's just eczema. But you guys see, we see patients who are up 24/7, wake up with bloody sheets, getting infections, can't go to school, all of those things, and that's anything but just eczema. So that's where the depression and anxiety comes in. And I always tell that cadre of providers is like, you know, any of us get poison oak, poison ivy for a couple of days, it drives us crazy, right? If you got an itch, it wants to be scratched. These kids have that 24/7 without necessarily a hope of cure. So that sort of puts it into perspective in terms of depression and anxiety. The other sorts of things that may be a little bit more surprising, one thing that's not even on here, we didn't put on here, is lymphoma. Why does that matter? Well, the box warning with topical calcineurin inhibitors like pimecrolimus and tacrolimus, that's what the box warning is all about, right? Skin cancer, lymphoma. Well, there's an independent risk of lymphoma with inflammatory diseases like psoriasis and atopic dermatitis, which confounds that potential adverse effect of the medicine itself. That sort of is a segue to the yellow here. You see a lot of cardiovascular things, right? We've learned in the last 15 years the pretty strong links between cardiovascular outcomes and psoriasis. It's an inflammatory state. We've known that psoriasis has had joint disease, right? But pretty clear that there's some significant cardiovascular risk factors. And can we prevent those by being a little bit more aggressive treating the psoriasis early on is an active question in our sphere. Here, are we going to get to the same thing? As you can see, it's yellow, it's not green, it's not as strongly linked as these other things, but intriguing. And it matters. Why? Because some of the things we'll talk about later, JAK inhibitors. You guys are familiar with upadacitinib, and I'll say, I may say brand names once, just in case you haven't heard of the drug. I think it's ridiculous to say a name that doesn't make sense just to sort of abide these CME rules. So if someone wants to put me in CME jail, you can do that. But I'll say these things one time in that case. So upadacitinib is Rinvoq, used for a lot of different things, including atopic dermatitis, and a box warning that will scare your parka off of you in a cold winter day. It's so frightening unless you contextualize it, which we'll do later. So you probably all know personally, maybe, or certainly know of Mark B. I call him from Colorado since I can never say his name, but a wonderful allergist. He was the lead author at National Jewish, who was lead author on this 80 yardstick, which we've used for years. And as you can see here, can you see my pointer? Yes, you can. So this was 2018, right? Dupilumab came out in 2017. So there's barely been any experience, certainly none in kids at this point. And this was their yardstick, which already had Dupilumab here after our old not favorites, systemic steroids, cyclosporin, methotrexate, et cetera. If you're able to read this fine print down there, it says Dupilumab safety and efficacy record already for those of us in terms of our personal practice, put it ahead of these other things. That was with less than a year of data. And now these others have sort of been left behind. Well, they updated the yardstick just last year, really just to sort of weigh in on the evolving landscape, which we just talked about. Tralokinumab, an IL-13 blocker, topical systemic JAKs added to the yardstick. Well, I just said, I can't remember when I said it, so it may have been, some of you may not have been in here yet, but just in the last month, one new topical approved yesterday and 2 new systemics approved for atopic dermatitis. So clearly not within the purview of this update. But they did talk about vaccines and Dupilumab specifically. As you know, the biggest question for us now that Dupilumab is approved down to 6 months of age is vaccine schedules, right? That's a very busy time for vaccine schedules. And some of the MMR, some of the very important vaccines are live and contraindicated for users of Dupilumab. And so there are many of us, and there are publications to this effect, but it is still on the label, contraindicated live vaccines. Many of us believe that will change soon. I have that discussion with many parents, and if it's possible the vaccine to get on schedule before you start the drug, great, that's ideal. Not always an option. So when this is a relevant discussion, and it's really challenging for a variety of reasons to squeeze those vaccines in, then I have had that sort of shared decision-making discussion with parents and pediatricians and use live vaccines in patients on Dupilumab. But for the record, it's contraindicated. Here's the pipeline. This is a National Legs Association, that website you can Google yourself. It's probably different this week than it was several weeks ago when I did it, but that's just absurd. And why I will never, ever again agree to be co-chair of the American Academy of Dermatology Guideline Committee, because it's gotten to be too difficult. But with that said, let's just dive into the topical therapies. Crisaborole, potato, however you want to say it. Eucrisa is the brand name. You know, this was sort of the topical holy grail for we pediatric providers when it came out, because it's a non-steroidal, no boxed warning like the TCIs, pimecrolimus and tacrolimus, Protopic and Elidel, and is approved down to 3 months of age. When are parents most terrified of using a steroid? At 3 months, right? The youngest kids. And this is like checks all those boxes. Good. Put it on the child. The child screams bloody murder. Not so good. It's got a really much higher rate of application site reaction and stinging in real life than it did in the clinical trials, of which we were a site. It was years ago, so I didn't put it as on my disclosures, but we were one of the sites. At my site, I had 7 patients enrolled. 1 of them had stinging. You know, Vaseline, for goodness sakes. Many things have that rate of stinging. So taking the all comers, it was 4.4% had stinging. In real life, there was a post-marketing trial done in adults on the face, 50%, 50%. So it just is not proven to be as valuable an option for us. So how well does it work? You know, somewhere between over-the-counter hydrocortisone and triamcinolone, depending on who you talk to. So it's, you know, can be helpful in those in whom it doesn't sting, but that's been the real challenge. Newest prescription option, so roflumilast cream, just approved this past year, is a topical non-steroidal, we'll talk more about it in a moment, non-steroidal like the drug we just talked about, crisaborole. It is a topical phosphodiesterase inhibitor, so non-steroidal. It had to fill this niche of everybody loved the safety of those drugs. So what is an oral phosphodiesterase inhibitor? Otezla, apremilast, right? You've heard of that drug. We don't check blood tests when we use it. It can have some GI stuff, some arguable depression stuff, but don't even monitor blood tests. So safety-wise, this class of medications is really quite good. Approved down to 3 months of age, the one we just talked about. So what this drug had to do is it had to not sting. And sure enough, in the clinical trials, it stung much less, and it seems actually more effective. So good with regard to the crisaborole. Jury's out, right? Because the crisaborole was 4.4% in clinical trials and way more in real life. We'll see about this. It's too new for me to really be able to weigh in with a personal opinion on that. Tapinarof, I will talk more about that in a moment too, approved literally yesterday for atopic dermatitis. And then ruxolitinib cream is a topical JAK inhibitor, which is approved for atopic dermatitis. We'll talk a little bit about it in a moment. But also a drug for vitiligo, which for me, 56% of my patients are on Medicaid. I almost never prescribe ruxolitinib for atopic dermatitis because I have other things and I can't get it approved for my patients. For vitiligo, thank you. We've never had anything. And so we're about to start a clinical trial at our site because it's approved down to 12 years of age for vitiligo. We're hoping to get it younger, so we're going to start that soon. This is the roflumilast. So this is the topical phosphodiesterase inhibitor, just approved as a 0.3% cream for psoriasis, I don't know, 2 or 3 years ago. But much more recently, I guess there's a foam version for seborrheic dermatitis as well. That's nice. Foam's much more agreeable in the hair or hair-bearing skin. And then a smaller percentage, 0.15%, was the one that was recently approved for atopic dermatitis, down to 6 years of age. You'll see these varying ages of approval. Mild to moderate disease. This was a paper in JAMA Dermatology looking at, and these are hard things to read, but basically these are itch scores. And you can see sort of the Kaplan-Meier placebo versus drug. So you can see that itch improving. What's that bar? 7 days. So you can see that separation pretty quickly for a topical drug, right? We've had systemic drugs, right? Methotrexate, let's take that as an example. I'll briefly mention it later because I still use it since I have 56% of kids on Medicaid and they don't get approved drugs very often. Methotrexate, you've got a kid who by definition is an in extremis, right? They're losing sleep, they're missing school, they need something. Prednisone helps for a week. I try not to use it at all, but it's not sustainable. So, okay, fine, we're going to go on to the systemic medication. We're going to check blood tests, all of these things, and your child may be better in about 2 months. The onset of action of methotrexate is terrible, and yet we use it. So here you see a topical. That's systemic methotrexate, a topical, getting this sort of separation and itch in a week. That's pretty good. And these are just some pictures showing you the same thing. This is an IGA of 3, moderate disease, down to 1 or 0. These, gosh, you can barely read these. I can barely read these unless I get my patient's favorite broken glasses trick going here. And you see that what I noticed here most is a little bit of headache relative to the other, which interesting for a topical medication that you're not using on a large surface area, but seemed to be something that popped out here. But really, this is what we watched most is the application site reactions, and more than placebo, but considerably less than the drug it's putatively replacing the crisaborole. So in summary, non-steroidal once a day. A lot of these new topicals have gone from twice a day to once a day, which, right, we prescribe BID topicals all the time. They probably get used once a day at best anyway. So it's really getting closer to reality. That's probably the lowest hanging fruit in terms of cost effectiveness with topical steroids. There's not a lot of good evidence that using topical steroids BID, as we all write for, is any better than once a day. So less medicine, less money, less side effects at once a day, and probably about similar efficacy. So probably worth remembering that. So as I say, wait and see with regard to how this fits in. This is the one that was approved yesterday, therapeutic aryl hydrocarbon modulating agent. You're welcome. Tapinarof. I will say the drug name just once, Vitama. Again, I have no idea how it's supposed to be pronounced. But this is the pathway here. So here's that defective barrier that we've talked about that is the sort of the sine qua non of atopic dermatitis. This is the aryl hydrocarbon receptor here. You see that sort of direct pathway to the neurological component of itch. So not directly working on cytokines like Dupilumab, not directly working on a more common constitutive pathway like the JAK pathway, but working directly on nerves and itch, which the systemic medication that was approved just last week that we'll talk very briefly about is also, it affects IL-31, which some people call the itch cytokine, also sort of works in a little bit different way than those we've been accustomed to. This was just a phase 2b trial of mostly adults, some adolescents, that varying, they're trying to figure out, right, the proper dose here. You can see EASI 11.3, what is that? That's moderate disease. That's moderate disease, probably the equivalent of a score out of maybe 20, 25, perhaps. And you can see here that down getting to the primary outcome of interest, the IGA 0, clear or almost clear. You can see the 53%, if we kind of go further, 53% with the percentage that ended up being the 1, that's actually should be QD, not BID, to 24% with placebo. So a lot of these trials with these topicals have placebo rates that are pretty good, 25% clear or almost clear with just the placebo. Well, that's because the vehicles that they're being made in now are really quite good. And so, you use a topical of any sort, if it's not got fragrances, it's not got things that are going to make you worse, then it's probably going to help. So this is also similar, looking at it easy, sort of the Kaplan-Meier curve and seeing just sort of that drop and that separation here, a little bit, takes a little bit longer here, about 2 weeks before you see that good separation, very tolerable. So in summary, non-steroidal approved for once daily use in children 2 or older. So that's a time when we really do need some non-steroidals, because we're not going to really talk about, because it's not new, this is an update. We're not really going to talk much about tacrolimus, protopic, pimecrolimus, Elidel. They've been around for 20 years. Approved to 2 and older. Canada, I'll show you one slide later that talks about some younger approval in Canada. But that box warning, parents who are steroid phobic for using things on their 5-month-old, and they're like, no steroids, are rarely calmed by a box warning that talks about lymphoma, I found. It just turns out that doesn't really reassure many of them. So even though we are very comfortable, we use it for 25 years, there are plenty of studies, position papers, many I've written that have said these are okay in younger kids, approved now in Canada down to 3 months of age. That actually helps some parents get over that psychological hurdle. It's still, we need something without that language. And this is going to be one of those. What about topical ruxolitinib? It's a true AD1, and they're all duplicative trials now, so you can just look at one side of this, and you can see here again pretty quick separation for a topical agent. These are patients 12 and older, IGA of 2 or 3. That's mild to moderate disease. 3 to 20% body surface area affected. That upper limit is going to recapitulate itself in the label, which says don't use this on more than 20% body surface area. If you treat vitiligo, you might, if you're scrutinizing labels, I realize you probably don't treat a lot of vitiligo, but you might get asked about it. And this is a drug, hey, let's do both. Let's treat your eczema, which I'm seeing you for, and you got vitiligo, great. 2 birds with 1 stone, or if you're from PETA, to what was it, 2 birds with 1 stone, feed 2 birds with 1 scone. That's what you're supposed to say. That's what now you don't kill anything. So this is something you could use, but in vitiligo, you only use it for 10% body surface area. Why? Vitiligo every day, right? You're not seeing that thing all of a sudden gone. Okay, we can take a break now. So atopic dermatitis is a more pulsatile, episodic sort of treatment. So we can take those breaks. And that's why 20% eczema, 10% vitiligo. So not a lot of stinging with this drug. Excellent. Low system exposure. Excellent. Still gets that lovely box warning that we'll talk about for a topical agent, which is kind of silly. Even for the systemics that we use for eczema, that's dubious what I just said. That's my opinion, dubious. But it is crazy for them. So this is just, the question my residents and students always come in and say, okay, great, there's this new drug. Is it hydrocortisone or is it clobetasol? Right? We want to know how strong it is by comparing it to something that we use every day. And here we actually have a nice trial that looked at ruxolitinib versus vehicle versus triamcinolone cream and the percent of IgA responders. Here's the triamcinolone and here's the ruxolitinib. That's pretty impressive because we all know triamcinolone works. So this drug works. I don't use it much for the reasons I talked about, but this drug works. So summary comparable to a mid-potency topical steroid. That's great. Safe. In terms of the studies, the box warning is daunting. So let's move on to systemic therapy. How are we doing? Okay, we're doing it. So first of all, who should get systemic therapy? There are good papers. This is International Eczema Council that sort of looked at this. First of all, assure the diagnosis. What can look like eczema? Everything. It's just can be very protean in its manifestations. A lot of times you sort of gestalt it at the doorway. Great, that's lovely. You can do that. But there are times where I still, good Lord, I've been doing this forever, and this is something I've been focusing on. And I have kids come in, I'm like, is it psoriasis? You know, and there's overlap, right? There are kids who have this atopic dermatitis psoriasis overlap, and then there are kids who have cutaneous T-cell lymphoma, and it's been treated as eczema forever. I had a kid, it's probably been about 3 years now, but I had a kid who came in for refractory eczema, and sure enough, they had sort of an ill-defined scaly rash. It was more extensor than flexural, but that doesn't, you know, they don't always abide the rules there. Then I looked at their knuckles, and they had these discrete little papules on their knuckles. And I was like, okay, I know what this is. This is dermatomyositis. So obviously you're having trouble climbing stairs? No. Oh, you're having trouble brushing hair? No. And so I was going on down my list as a 12-year-old kid, on down my list, asking him these weakness questions, because I knew he had not eczema. And sure enough, no. Finally, I just thought he was throwing me a bone. And he said, well, I used to beat my friend in a foot race, and now he beats me. His CK was 13,000. So kids are amazing at compensating for things like that. So he was just sort of destroying his muscle with inflammation. And still, the only thing that had changed in his life was he couldn't beat his best friend in a foot race. But it had been called, this dermatomyositis had been called eczema because the rash itself, yeah, there's some similarities. So bottom line is sure the diagnosis, the biggest one off that sort of resonates with you guys, I would think would be rule out allergic contact dermatitis, for instance. That is a big struggle for me sometimes trying to say, is it one or the other, or is it both? And what you're using to treat one is causing the other. So these are all issues that we deal with. This was our guideline in 2014. That was it. The non-steroidal options for systemic therapy were those. Since that publication, as you see, Dupilumab, Tralokinumab, Lebrikizumab, Nemolizumab, the JAKs, upadacitinib, abrocitinib. This is all just systemic therapies approved since 2014 for atopic dermatitis. Well, just to briefly talk about these, because we do use them. Cyclosporin is, we talked about methotrexate taking 2 months. Cyclosporin, you know, closer to these sorts of new drugs in terms of onset of action, you know, week, 2 weeks before they start seeing relief. So I tend to, absent sky-high blood pressure, you know, I treat mostly kids. That's not as often a problem as those of you who treat adults. So I usually can get away with that. Absent renal problems, things like that, I tend to use cyclosporin as a bridge. I try to calm them down with cyclosporin while I'm trying to get one of these newer things that I think are safer and more sustainable approved. So I still do that a fair bit. I don't use as much methotrexate for the onset of action business, but I do. Mycophenolate mofetil I tend to use for other things, and those others I don't use much. Well, adjunctive therapies, and I will also say that picture on the right, harking back to assure the diagnosis. Atopic dermatitis is not just protean in its manifestation across all the population. Certain populations, oftentimes it looks different. African Americans, much more common, first of all, atopic dermatitis, and frequently have much more lichenification, as you see here. You're like, oh God, is that psoriasis? It's on the, you know, it's on this side, it's not on this, oh, it's on this side too, you just don't see the picture, but it's on this side. But boy, that is so lichenified. That is really common in patients of darker skin types. Follicular accentuation. You'll see a little baby, a 1 or 2 year old with, wow, you know, the mom says it itches all the time. They're sitting in your office for allergies, but you're not seeing this. But you're seeing what looks like perma goosebumps all over. That's eczema. That's inflammation. That's follicular accentuation. And that's a very common manifestation of atopic dermatitis in patients with skin of color. So that's why this can be such a tricky disease sometimes, as it can look different in different patient populations. That also raises the problem, what do you use, right? It's all over. You don't want to treat an 8-month-old with a topical steroid really of any strength, but it's not comfortable to treat all over, and yet these kids are itching all over. What do? It's a struggle, first of all. One, it's not on my slide, so I'll just tell you, one of my favorite things to use in that context is a product, fluocinolone oil. If you're familiar with it, the brand name is Dermasmooth. We use it a lot for scalp psoriasis or seborrheic dermatitis because it's an oil. So foams are one thing, but oils also very easy to put into hair-bearing skin. It is a scalp oil that I use all the time on the body. Why? Because it's the weakest prescription strength steroid, number one. So it's a class 6 steroid, so it's very weak. And yet it punches above its weight like nobody's business in terms of helping eczema. Why? I don't know, but maybe because it's an oil, it is so easily spread and so compliance, maybe the why piece, but If you haven't used it and you have a patient where you really don't want to put triamcinolone on such a big surface area, think about if you can get it. It's another struggle for us because there's really not an equivalent agent that I can give, give generic with. And it means, oh my goodness, okay. This could be a challenge because I don't have any water. Should have brought some. Antihistamine limited role. You guys use antihistamines for plenty of things, as do I. Everything that's looked at the role of antihistamines just for the itch of eczema, not concurrent rhinitis, not concurrent rhinitis and conjunctivitis driving the eczema, which we all know happens too, but just eczema. Here is your cetirizine to take at bedtime for your itch, right? Non-sedating at bedtime, so you're not even getting the benefit of sedation by giving it at bedtime. Here you go. It's not helpful. It's not, it's been shown time after time, it doesn't help the itch of eczema. Helps all those other things and may help eczema, one step down the line by helping the thing that's driving this. Sure, it can do that, do it all the time. But when I use systemic antihistamines, mostly for the itch of eczema, it's really for the of eczema. Because we have plenty of kids who will go to sleep looking decent, right? And actually they aren't even itching that much sometimes during the day because they're distracted. They're doing that, got the clothes on, they're distracted, they're doing their thing. Then they go to bed and it's them and their itch. That's it. And so they're either not getting sleep because they're scratching themselves or they're waking up early because they're scratching themselves. And there, the sedation piece, and I'm very clear about the parents, that's what I think we're doing. But that it's interrupting the itch scratch cycle, so you're not just knocking out your child. There's value to it. So I do use it. Antibiotics with concurrent superinfection, I try not to use them otherwise. Unproven, apremilast we mentioned, omalizumab, some more recent data that's maybe a little bit more encouraging with regard to atopic dermatitis specifically, not urticaria, not anything else. IVIG, vitamin D, other things we've thought about. So this is just a graph that a little cartoon that I created just to sort of paint the picture of all the different mechanisms for systemic treatment. So Th2 cytokines receptors, all three are now approved. We'll talk about all three to a certain extent. IgE, omalizumab, we talked about. This mechanism, this target OX40, it's coming. The data I've seen has not made me wildly, I'm not like waiting so much for it to come because I've not been super knocked over by it, but it's a different mechanism. And who knows, maybe we'll be surprised. Mesenchymal stem cells, JAK inhibitors we'll talk about. This one, tofacitinib, was the first one we used, but now it's the only one on this list that we never use, just because the others work better and they're safer. The boxed warning was generated in a trial using this as the JAK inhibitor, not the others. And that matters. They work, JAK1, JAK2, JAK3. There's different types of JAKs, so that matters. Microbiome work, pruritus, we talked about nemolizumab is one of the new ones that was approved, and these others we will not talk about. They aren't approved yet. So this was a systematic review and meta-analysis of all of the therapies. Look at all these trials, look at all these different treatments. That's basically encompassed within all of those. There's that chart that I just showed you. It's somewhere in there, that mechanism is touched upon. And the conclusions of this study, I'll show you a slide. The next slide kind of gets at it too. High-dose upadacitinib, so that's the Rinvoq that I mentioned. High-dose upadacitinib was the most effective. There are patients who will take this drug and say within 1 day they're itching less. It's an incredibly rapid onset. Oopsie, I'm gonna go back. For multiple outcomes, but also among the most harmful. There's the boxed warning. Dupilumab, Lebrikizumab, and Tralokinumab are generally of intermediate effectiveness, but favorable safety, and that's listed here. The green is among the most effective, the red is among the most harmful, and as you can see, upadacitinib high dose gets both, most effective and potentially most harmful. So this just sort of puts them all on a page. We'll talk more about the safety in a moment, but this is just efficacy. So the JAK inhibitors, abrocitinib and upadacitinib. So these are not comparative trials. There's one nice comparative trial that I'll bring up later that is upadacitinib versus dupilumab. That was the trial. So that you can say, okay, this did better, this did worse. These are all just sort of plucking numbers from different trials. So apples to oranges for sure. But that said, upadacitinib, 62% clear or almost clear on monotherapy. Abrocitinib, 44%. So this is Rinvoq. I said this is Cybinco, if you care to hear the brand name ones. So do I use this much? No, I don't. It doesn't give me much over this upadacitinib. So I tend to use upadacitinib if I'm choosing a systemic JAK. If they've got alopecia areata, we said that happens a lot, right? Well, FDA-approved treatment for alopecia areata is baricitinib. It's EMA approved. In Europe, it's approved for atopic dermatitis. So if you've got those two things, you could feed two birds with one stone by using baricitinib for their alopecia areata and their eczema, and maybe get that approved. But if we're just talking about atopic dermatitis, I tend to choose upadacitinib. My opinion, not that of the American Academy of Dermatology. American Academy of Dermatology said they are all good. Biologics, same deal. Dupilumab is far and away what I use the most. Why? I mostly see kids. It's been around the longest. It's approved the most often, and it's approved down to 6 months of age. A word of caution there. I don't think I'd talk much about it in a moment. I may not have time. Oh, okay. Dupilumab approved down to 6 months of age. Well, that sounds like, wow, that's fantastic. And it is. To have a systemic biologic medication approved down to an infant age. Well, we were one of the sites of the trial. So that tranche was 6 months to 6 years of age. How many 6-month-old to 2-year-olds did I enroll? Not a one. If I come to you and say, oh, your child has bad eczema, would you like to enter us an experimental medication? It's a shot once a month for your 7-month-old? Probably not. That was the answer that I got from everyone. And yet, it was approved down to 6 months of age. So it must be, oh, well, like many of these trials, they were over in Europe. They were like, where they didn't have access to other drugs, Poland in particular. So these amazing numbers with clinical trials because they don't have the same access to Dupilumab that we have. And so it's like that or nothing. Then it's a different answer, maybe, if your kid's miserable. And so across the globe, guess how many patients were enrolled in the 6-month to 2-year-old age range in this drug that then got approved, remember, for this age group? Any guesses? More than 50 or less than 50? More than 20 or less than 20? Less than 20. 11 across the globe. 6 on drug, right? Placebo-controlled drug. 6 patients. And yet they approved it in this age group, which I found stunning, which I always disclose to parents. I'm like, because that's, oh, the imprimatur of the FDA. Lovely. This is so fantastic. Well, on the basis of nothing, right? 6 patients. And so I always tell them that. Then I will tell them, so my daughter is a freshman in college doing a debate thing now, so she always has to take a position that she doesn't believe in and argue it, which is lovely and fun and instructive. And she comes home from school today from college, so it looks like. But this is something where I will say, okay, well, what does that also tell us? They approved it with no data, which means the older kids and the adults in whom it's been used, it's been pretty good, right? So you can look at it both ways. So that's Dupilumab, 38% clear on monotherapy. Tralokinumab less, sort of like the abrocitinib. I've got why? You know, I don't use that one very much. It's not approved to as young an age. We haven't used it as long, and it doesn't seem to work as well. So I don't use my opinion. American Academy of Dermatology, all good. Lebrikizumab, this was just approved this month, down to 12 years of age. So everything but Dupilumab is 12 here on this list. IL-13 blockers. You see these IL-4, IL-13, and then just IL-13, very similar mechanisms, which might beg the question, do they have similar side effects? They do. We'll talk about it later. Conjunctivitis. You got bad conjunctivitis with Dupilumab? Let's put it on Lebrikizumab. You may get the same problem. You may not, but you may. Nemolizumab, different mechanism. IL-31, that was that nerve pathway, right? That was the itch cytokine. This was the one that was approved, just approved. So it's been around for approved in Japan for several years for atopic dermatitis. Approved in the United States for over a year for prurigo nodularis. Just approved this past month for atopic dermatitis. Haven't used it in real life at all. Used it in a clinical trial. So this is something that we sort of we'll see how it tends to help us in real life. But if you do have a child with bad conjunctivitis or something from Dupilumab, it likely that's not been a signal at all. The flip side of that, to take the contravening argument there, is what does Dupilumab also treat? Asthma. What is one of the adverse effects of special interest of nemolizumab? Asthma. That's another place where we get down to here, co-morbidities, right? That's how we help, with shared decision making, choose a drug for a patient. The biologics, no blood draws. So when I talk about patient might, I see just kids and so like, oh, it's a shot. No, no way, no way. They're like, okay, there's a pill, but we check blood draws. Oh, no way, no way. So it's just like pick your poison in terms of which of these you want to use when you have to use one. And then the box warning we'll talk more about because it's pretty daunting. This is the one that was just approved this past month. This is a New England Journal paper, phase 3 trials of Lebrikizumab. And you just see versus placebo, you can see the clear or almost clear there, 43%, Dupilumab-esque. You can see the conjunctivitis, as I said, it's an IL-13 blocker, so similar sorts of side effect profiles to Dupilumab, and sometimes you can get some eczema exacerbation as well. So when you have these new things coming out, these companies have to say, all right, there's already a decent drug. So when Dupilumab came out, I had a list like 3 pages long of people that said, as soon as this clinical trial is available, my kid's in it. Let me know, give me a call. And our site is so cumbersome to get things approved that I basically had 3 weeks to enroll the very first trial, 3 weeks to enroll because it was competitive enrollment. All the other sites had filled up all the slots. And so I ended up getting like 10 kids in 3 weeks for Dupilumab. Every subsequent trial for atopic dermatitis is like, really difficult to enroll because they've already, why do all the clinical trial BS when you can just get it in the regular clinic and not have to do blood draws and not have to come in every 3 weeks or whatever. So, so these new drugs have to say, okay, how do we distinguish ourselves from the one that already works? And so going back to the nemolizumab, that IL-31, so I'll just add this again, and we're just learning about all this, but this is once a month shot, right? So instead of it is only once a month shot. So that's half as many shots as Dupilumab for an older kid or an adult. Kids 0 to 6 years of age or 6 months to 6 years of age for Dupilumab, they don't load and they only get a monthly shot. So some kids with Dupilumab, it really is only Q4 weeks. But for adults, if that's who you mostly see, then that's different, once a month shot, which is good. There's also data to suggest a down step. So after a certain number of time, if they're doing well, there's data to say, yeah, go to every 2 months. That's nice. This is Lebrikizumab, and I segued there because this is the same data. Here you see these patients, they responded to Q2 weeks Lebrikizumab, and then they went off drug at 14 weeks. And then their EASI 90% improvement in their body surface area, that metric EASI, 11 half-lives later is still there. So there's a durability with Lebrikizumab that at least hasn't been shown with Dupilumab. I've had plenty of kids now who I take off Dupilumab and they actually stay good. So it happens. Did they just go out of it? Did you sort of reset their eczema from good and bad days up here to good and bad days in? I don't know. But this is data to suggest there may be a durability of the drug that's maybe different. So this was that trial, that comparative trial, upadacitinib, the JAK inhibitor, versus Dupilumab in adults. And here you see the top bar. You see that they're both pretty quick. The upadacitinib's on top, a little quicker, and also reaches a little higher level of percentage of clear or almost clear. So 70%-ish versus 62% in this trial. At least in this comparative trial, it works a little quicker, maybe works a little better, but ultimately gets to a very similar place. What about safety? All right, still good. So the IL-14 or IL-13 biologics, this is one of the changes in the slide I put because I just had biologics before, but now IL-31 is a biologic that doesn't have the same list as we talked about. So conjunctivitis ranging, in the trials, 1 out of 10. But in real life, 5 to 25%. I will say this, if you're sort of risk assessing conjunctivitis in a patient with Dupilumab you're going to treat, if they don't have anything up here, no periocular dermatitis, no, 8% of patients with atopic dermatitis have some sort of ocular complication, whether it's keratoconus or vernal conjunctivitis or what have you, 8% of patients have that. If they don't have it, and they don't have any periocular dermatitis, they're probably way, way less likely to get the conjunctivitis from the Dupilumab. It's a combination of the drug and the disease, not just the drug. How do I know that? Patients who get treated with Dupilumab for asthma don't get conjunctivitis, which is really interesting. So other side effects, less common, but be aware. JAK inhibitor, here's that box warning. So this is real, for sure. Odds ratio of getting acne is very high. It's often called JAKne, isn't that cute? It's real, but it's manageable. You see these other things, zoster, no fun, real risk of any of these things. Get vaccinated. The monitor, yes, we monitor baseline labs. And how often do I monitor on JAK inhibitors? Usually baseline, 1 month, and then every 3 months. And that's my opinion, what I do. Others do a little more, a little less. Here's the box warning. So again, for topical JAKs even. So no big deal, just cancer, infection, heart disease, blood clots, all-cause mortality. It's no big deal. But we'll guarantee your child's itch. It just oftentimes is sort of a disconnect for parents, and they shut down the second that I talk about it. But if you are, if it's appropriate, I never, try to cajole a parent into anything other than to make them realize the cost of not treating. Right? It's very easy to see the cost. And even though I don't think this is a cost of this drug, it's very easy to hear that and be daunted, and then forget all the sleepless nights and the infections and the not wanting to go to parties and school and all that stuff. So I always bring that to bear, and then of course it's their decision. But I do contextualize this. We've spent 25 years now contextualizing tacrolimus, pimecrolimus, and the box warning there. It's important to contextualize this one to say that the trial in oral surveillance or whatever it was called that generated this box warning, number one, tofacitinib, as I said, different JAK. Number two, patients 50 and older with rheumatoid arthritis on things like methotrexate and prednisone as well. They were basically enhancing that patient population for cardiovascular risk factors to see if this drug, if the JAKs, tofacitinib specifically, had more than Enbrel. That was sort of the idea than etanercept. So that was the idea, a very, very, very different scenario than your healthy child or adult with atopic dermatitis. Does that mean to say that I just mention this and say, well, because of that, just forget about it? No, of course not. Is there a strong family history of heart disease, of clots, of all, maybe that, not great idea. Cancer, all of those. So it's all about risk assessment. But there have now been many studies which I include, at least, well, those are more generated. There are many studies now that have sort of shown in atopic dermatitis patients, these things aren't being seen. But we haven't been using them for very long, so we have to be careful. So we'll close just with the guideline discordance. As many new medications as there are guidelines, these are important for many, many reasons, including getting these things approved. If the FDA says it's good and then it's on a guideline, then maybe we're more likely to get it approved by insurance companies when we need it. That is real. These are all the guidelines since 2018. Europe, Japan, Thailand, Taiwan, Mexico, it's all over. And these are my dermatologic sphere. There are probably doppelganger allergy guidelines in all these countries as well. But the allergy guidelines that I want to talk about are the Quad AI ones versus ours, because we both use GRADE. What is GRADE? This acronym for assessing the evidence, which does get at the evidence, as you might imagine, but then they have ways to downgrade it, risk of bias, imprecision, on and on. It's a very good system. It's what UpToDate uses, for instance, to generate their recommendations. So it's a good system, and yet we both used it. And came out with different recommendations in some areas. So who were these folks? So our group, 10 dermatologists, 1 allergist, 1 methodologist, 1 social worker, and our AAD person. With 4 publications, the most recent pediatric ones coming out this year. Quad AI, same system. Here's the big difference. So when we did our 2014 guidelines, we had Julie Block, who is no longer the CEO of the National Eczema Association. Right there in every meeting we had. Incredibly important voice. Incredibly important voice. For some reason, well, I know the reason, but the American Academy of Dermatology decided not to have that anymore. Not to have patient advocates, convoluted logic, makes no sense to me. That's definitely my opinion. That is the reason that these recommendations were discordant, because let's look at the Quad AI, patient advocate there. So This was our slide. This was our summary slide, and we've already talked about the main stuff. So basically, green things here, we talked about strong recommendations in favor of the intervention. All of these green things, Dupilumab, Tralokinumab, Upadacitinib. We even said Baricitinib, even though it's not approved in the United States, approved in Europe. And then, conditional for the old stuff, right? Well, never mind that the allergist slide is way prettier. I'm just going to throw that out there. I can't get around that. I'm sad. It makes me sad. But this was their recommendation. So same sort of way to look at things. This was the systemic, same sort of things to look at. So let's sort of distill it. So ruxolitinib cream. We talked about the topical JAK, right? The way better evidence than topical steroids because you study topical steroids for atopic dermatitis. So tons of evidence in a heterogeneous population, patients with skin of color, all the things we never used to think about in clinical trial. Good. Safe, all these things. And so basically that's what we did. We followed the evidence in favor, evidence-based, short and longer term data, now showing good drug tolerance, all this good stuff. What did Quad say? Conditional against. Why? Because they're quote unquote most well-informed patients with mild AD would prefer to avoid these mild risks. Hey, that was their conclusion. And it's distressing because conflicting guidelines are not good for this. Just gives any insurance company a reason to say no when you as the provider may say yes because it's got good evidence. So I get why this happened, and actually, as I already said, I don't use this much for atopic dermatitis, so I actually follow the quality guidelines, not because I think the risks are the reason, but because I think we've got other topicals for mild to moderate disease. We don't need an expensive new one and I can't get it anyway. So this was a challenge. Bleach baths, another place. We favored it in 2014. We didn't discuss it much in this because nothing's new, and so we didn't pluck it out and relitigate in 2022. But we were in favor then. We're in favor now. Quad AI, conditional against for mild disease. Basically, a well-informed patient. It's just why bother? Yeah, that's reasonable. I believe in bleach baths not as treatment, not as, oh boy, Johnny's flaring, start the bleach baths, as prevention. Why? Do they prevent infection? Yes, that's why they were first studied in 2009. But in that trial, controlled trial, right? Bleach bath, fake bleach bath, however long the trial was, 12 weeks, I think, looking to see if the bleach bath group got fewer staph infections. They did. Wonderful. As a recommendation to prevent infection. Well, the bleach bath group's eczema severity got better everywhere but above the neck, where they weren't in the water. So it's now been shown that the concentrations we use in bleach baths do not kill staph. The concentrations are too low. So they prevent infections by healing the barrier and making the eczema better. I pitch bleach baths as topical, non-steroidal anti-inflammatories with no box warning. That's how I speak of bleach baths. It's something that I find incredibly helpful for many, not for all. And the last thing I always say to patients and parents, if you do this and you do it the way we said, they take the bleach bath, they rinse afterwards. So they oftentimes say, well, because I use the swimming pool analogy, chlorine, Clorox, it's not so bad, trying to make them think I'm not a quack. And then they're like, well, little Johnny goes to the swimming pool and he flares every time he comes home. I'm like, well, do you rinse off at the pool and then moisturize at the pool? No. And so that's the difference between the two. So they may get worse with the swimming pool, which you don't put in all the chlorine, right? Someone else does. If any of you ever been to Great Wolf Lodge, you're like, you're stunned the minute you enter the door because there's there's no infections for God's sake, but there's a lot of other nastiness. So methotrexate, all of these things, there were some divergent recommendations we won't dwell on in the interest of time. JAK inhibitor, strong in favor, conditionally in favor. It's not the evidence, and this I get, right? I mean, this is systemic. This is not a topical. This is systemic. And the box warning is very, very scary. And so most well-informed patients would place a greater value on the certain benefits than the burdens and lower certainty for serious harms. I can't even read that. Doesn't make any sense. But the well-informed patient said conditionally, not strong in favor. So important nuances. We talked about once daily use of topical steroids, calcineurin inhibitors. I thought I brought this back up. 3 months of age and older. So Quad AA guidelines gets it. That's where I love the well-informed patient, because the well-informed patient looks at the data and says we've had this for 25 years. And even though patients on systemic tacrolimus, I guess systemic tacrolimus, can get post-transplant lymphoproliferative disorder. There's no data that using it in topically has done that. Good data that it hasn't. And then there's even the confounding issue of the lymphoma risk in patients with eczema that we talked about. So Canada, 2 thumbs up. Quad AI, 2 thumbs up. We didn't go there. Recommend against adding topical antimicrobials, yes, unless there's infection. Topical phosphorus, we talked about them, I believe. Dupilumab for infants, and we talked about this essentially. I just wanted to call out how little data there was in the 6-month to 2-year age group. So challenges, we talked about that. Divergent recs are confusing. I was at Boston Children's for a number of years, and office 2 doors down was Linda Schneider. Does someone have a tissue? Look at that. I got to work with Linda Schneider every day, which was just a privilege and a joy. She is fantastic. So she and I are trying to proactively make sure that our guidelines are more coherent on the front end next time, so we don't run into this problem. So in summary, explosion of new medications has prompted the need for updated guidelines, good but imperfect coherence despite similar methodologies. And it's all about listening to our patients and tailoring treatment, even when I tell parents every day, you're going to be the expert in your child's eczema, not me. Here are the general rules and guides to follow, but if something I said clearly is not working, then dismiss me. Thank you very much. Any questions? We don't have time for questions. Any questions?
Chat.
Oh, okay.
This is Angela Fung. I'm curious what the average costs are for some of these topical therapies. Can we repeat it for the people on Zoom?
Yeah, if I know. So the average cost for top of these therapies, as many of you may be as well, we're sadly ignorant on many of these things. And in part, my defense for being ignorant is the cost for the same drug for patient A with private insurance is often different than for patient B with private insurance. It's often different here than it is in Massachusetts. And so it's sort of absurd. So I would say I have no idea what the cost of tapinarof is, the newest one there is. Do I have any idea of what I will say? When some of the newer ones came out, they were in the thousands of dollars for a 30-gram tube, which is, not going to happen. But that number was a floating target. And it's why our healthcare, one of the millions of reasons our healthcare system is not good. And so I have a very incomplete and frustrating answer for her because I share her concern.
And then the other question was, what was the word of the day?
Cloxinoxinide, medication. You ever seen the movie Bad Words? That's the word of the day. Great movie.
We'll have them email it out.
The word of the day.
Yes.
You guys have a word of the day?
It's to get steamy credits.
Oh. And so what do you say it now or what do you do?
No, it has to be official word, which I don't have, so.
Oh. Cloxinoxinide. Oh, yeah, sure.
You mentioned about that. In your practice, do you routinely try to get patients off Dupilumab after a certain time?
Yeah, so for those in Zoom land, the question was sort of endpoint with Dupilumab, and that's sort of the really important question, which is why maybe Lebrikizumab, the new one, is it different? Who knows? So to answer your question, do I try to get patients off Dupilumab in a certain amount of time? Yes. What I usually will do is, so if I put them on Dupilumab, by definition, they're not so good. If it's a kid who needs a systemic drug, they're not so good. So if they're not so good, it means they're probably not so good for a long time. So I really like to let their skin chill out for a while. So I'll say, let's put you on this medicine and get you better, step number 1. Let's keep you better for at least 6 months, step number 2. And then let's sort of read the tea leaves. What do I mean by that? Let's say it's a once every 2-week kid, not a once a month kid. Is their itch starting to peek its little head up on day 12, 13 when it wasn't on day 3, 4? Probably not so much ready. Have they, like most of us, not used their medicine every 2 weeks exactly on schedule? Have they sometimes missed a week and they're no worse? Well, maybe. So things like that, I try to get some hints. Absent those hints, I will bring that very important question up every visit. that they're on to every single visit. What do you think? How are you doing? Any reactions, any conjunctivitis, all that stuff? And if all is good, there are no real tea leaves to read. After a year, they're good. You know, their eczema is better. Then I try to say, you know what? Because it kind of depends on the age too. Let's maybe see how you do. And we know that the younger kids can do this once a month. So you don't necessarily have to stop at cold turkey. Let's go every 3 weeks. That can mess up your insurance approval, by the way, but you can try that. Or let's go to once a month and see how you do. We can always go back. Does that risk drug antibodies? Yes, not been a huge deal with Dupilumab as it has with things like adalimumab, but theoretical concern.
Thank you.